Today, this is going to be a high-level talk about lower urinary tract symptoms as a syndrome and how we might benefit from thinking about lower urinary tract symptoms as a geriatric syndrome, implications for translational research all the way to clinical practice. I'm not going to be diving too much into detail about specific symptoms. I think there's a case to be made that you could think of the whole syndrome or about specific urinary symptoms. Turns out a lot of the same associations are observed for many of the different lower urinary tract symptoms. So I'll be kind of focusing on the higher level implications of this. So would love for people to reach out and ask me questions or engage, talk about collaborations afterwards. So I'll call it LUTS for the rest of the talk, but lower urinary tract symptoms are well known to this group, include many of these symptoms here, basically a failure to store urine that is being generated and stored in the bladder, and or a failure to effectively void. It is very well known across many different countries. If you ask people in different age groups whether or not they have these symptoms and at different frequencies, that the prevalence increases quite dramatically with increasing age. And these associations are strongest actually when you ask about all of them together, because many of these symptoms overlap. But when you look at individual symptoms, the same trends are observed. Again, this is also seen in both women and men. There are important sex differences in terms of the relationship of LUTS with age. Urinary urgency with incontinence increases more dramatically in women than in men, although it does increase with increasing age in both. And then urinary urgency without incontinence increases more dramatically in men than in women. And there are also some sex differences in voiding symptoms that I won't go over. We also know a lot about many different inciting factors that affect pelvic floor function and symptoms. In women, in particularly, childbirth is a very important and well-studied, although there are many unanswered questions. What I am most interested in is less so these kind of inciting insults, but the slope of this line over time and how that line progressively, pelvic floor function declines progressively as we get older, and that slope can be lowered by certain inciting events, but also it can decline at different rates for different people. And it's always really interested me how little we know about what predicts someone being an A or a B, and the fact that this actually is occurring in both women and men. So there's something potentially universal about aging, that in aging processes that is causing our pelvic floor function and our ability to urinate normally to start to fail at higher and higher rates as we get older. A overarching framework for how I think about this problem is the fact that as we live longer, a somewhat inevitable fact of that, and regardless of what country you live in, is that people who live longer tend to also have more years living with disability and multiple chronic diseases. And this is true when you take a step back and look at average life expectancy and across nations, and it also is true within countries. Here I have the average life expectancy on the y-axis and the expected number of years lived with disability or disease on the x-axis, and you can see this is a trend that's occurring worldwide. When you look at specific individuals, as we get older, we start to accumulate diseases and disorders. And so it's been known for a very long time that someone who is in their 80s on average is much more likely to have 3, 4, 5, 6 chronic diseases compared to someone who is in their 20s. And what that means is that as we get older, many of these disease processes are the pathophysiology that leads to these disease processes has been occurring throughout our whole life. It has been accelerated by certain things that we do that are unhealthy health-related behaviors or exposures, things that we do and do not have control over, or slowed down by things that we are doing that are protective. And this idea has underlied a lot of the work in the Baltimore Longitudinal Study of Aging, which is an intramural NIA program. And it has changed, at least in the last 5 to 10 years, how we think about treating many different age-related diseases. And so just to kind of explain this concept a little bit further, folks who have seen versions of this talk have heard me go over this, but for those who haven't, one of the most important things for people as they live longer and get into older age is the number of years that they live a disease-free life. And so what that entails is we have lots of different diseases that are starting or preclinical. The risk of these diseases is increasing as we get older, but there will be one disease that will be the first age-related disease that a person develops, and that is kind of the end of their disease-free life expectancy. And then once that first disease occurs, actually their risk of developing other age-related diseases increases and will kind of happen in quick succession after that. There are some people who have above average disease-free life expectancy, and so these folks you can see will be older when their first age-related disease occurs. But that's what we also know is that many of the other age-related diseases, partially by definition, they have not occurred before this disease happened, but they once that first age-related disease occurs, they are again at increased risk of having multiple age-related diseases occur subsequently. And this is, some folks have maybe heard of compressed multimorbidity or disability. You can see that the number of years of one's life, if it were to be the same life expectancy, that one has many different diseases has been compressed in the second person compared to the first. And then there are, of course, other people who have accelerated aging, and these folks, either through environmental exposures, certain diseases are known to accelerate aging. They will be a younger age when their first age-related disease occurs, and then multiple different age-related diseases will occur in rapid succession subsequently. And the culmination of aging being the upstream risk factor and potentially causal biological mechanism of multiple different diseases, even if they happen at different time points for people who are aging more quickly or more slowly, is that near the end of life, or even for an entire decade, and I say end of life, I mean more in the later decades of life, older adults will experience a greater burden of multimorbidity, frailty, and disability. And our whole medical system is set up to address each of these lines individually. And as they occur, the first disease or the first symptom that a patient presents with, we address that. And then we wait for the next age-related disease to develop, and then we try to address that. And there is some attempt at preventing some of these diseases, but largely our medical system is set up to be very reactive. And what that ends up leading to is a very patchwork approach of trying to put Band-Aids on each different age-related disease as it occurs. And so if a Band-Aid is a medicine or a treatment, you can imagine by the time that you are in later decades of your life, you are by definition at increased risk and starting to develop multiple age-related chronic diseases. You are also starting to accumulate treatments for all of those different age-related diseases. And some of those treatments are going to interact with each other, are going to have their own harms and adverse side effects. And this is where the science of multimorbidity polypharmacy and drug prescribing cascades has really started to try to reverse some of that trend, because we have found that older adults who have a bunch of Band-Aids on them actually, in some cases, are worse off than if they had 2 or 3 Band-Aids. And if we, and then you can't just keep playing whack-a-mole and trying to treat each of these age-related diseases. You get to a point where your ability to actually improve somebody's quality of life, the ultimate goal of our treatments, is no longer attainable. This has led to a science of trying to determine why all of these different, seemingly very different diseases and in different organ systems are all increasing, and in the same people. It seems to be someone can have an accelerated someone can have increased risk of all of these different very heterogeneous diseases. And actually some of the biology seems to be overlapping when you take a deeper dive into risk factors. And so that has born the field of geroscience, where there's this idea that biological aging is a measurable process that's happening in cells in the entire body, and that different cells and tissues and organs are going to be exposed to different toxins and or stressors. But in general, many of the things that affect biological aging are actually systemic, and that in our earlier years, our bodies are aging biologically, but we have a lot of compensatory mechanisms and resilience to this increasing biological age at a cellular level. Eventually, those cells overwhelm the compensatory mechanisms and resilience mechanisms. And so you start to observe decompensation at the level of tissues and phenotypes that might manifest as inflammation or fibrosis, or at measurable changes in skeletal muscle, or measurable changes in lower urinary tract tissue function. Although that, again, we have many compensatory ways of dealing with age-related changes in our tissues. And so there are many people who have age-related changes in their tissues and in their organs that are not affecting their function. They have an enlarged prostate, but they have no obstructive symptoms. They have a bladder that actually has, when you do detrusor or urodynamic studies, they have bladder overactivity, detrusor overactivity, but they're not having urgency or storage LUTs. Those analogies are true across many different organ systems. People can have abnormalities in their muscle tissue, but actually have no functional impact. Their strength can be preserved, and ultimately their ability to function in their daily lives, the most important clinical outcomes, are preserved. But eventually, as phenotypic aging progresses, you will start to, when it hits a certain threshold, you will start to see functional impacts. It will start to affect voiding efficacy. It will start to affect ability to maintain bladder storage, and you might have urine leakage. Moving outside of the urinary tract, you will start to see decreases in muscle strength, muscle volume, muscle mass. And ultimately, you will see symptoms. People will be bothered. They will notice decreases in their ability to do things that are important to them. And you will see that they are unable to do activities that they used to once be able to. This is a framework that has allowed us to kind of put risk factors for different age-related diseases into these 3 different buckets, and to acknowledge that they are hierarchical and that you can't study one in isolation. To kind of bring this into a urinary tract function specific example, one form of biological aging is mitochondrial dysfunction. We know this occurs in almost all cells in the body are dependent on healthy mitochondria, and yet mitochondria become dysfunctional with age. But But many people are walking around with very dysfunctional mitochondria and absolutely no problems in their tissues, in their organs, and certainly in their function. But if we're talking about mitochondrial dysfunction specifically in the prostate, eventually the mitochondrial dysfunction reaches a point of overwhelming the compensatory and resilient mechanisms, and we start to see the core components of benign prostatic hyperplasia, including hypertrophy, inflammation, and fibrosis. And those things can culminate in a lower urinary tract dysfunction phenotype. And we know that all of these things increase with increasing age. Again, people can walk around with prostatic hypertrophy, inflammation, fibrosis, and even lower urinary tract dysfunction or voiding efficacy and have absolutely no impact on their day-to-day functioning. They may not notice, they may have no symptoms whatsoever, or they have mild symptoms that are not impacting their ability to do their daily activities and participate in life the way that they want to. So those are their symptoms, how bothered they are, their quality of life, physical activity, social activity, and ultimately morbidity and mortality. This is a very prostate-centric and urinary tract-centric example, but their mitochondria, we know in other organs simultaneously cause systemic inflammation. They cause massive metabolic disruption. They play essential roles in skeletal muscles, tissue, and myoblasts, as well as other muscle cells. Nerves are highly dependent on healthy mitochondria, and the brain is one of the most mitochondrial dense tissues. And so to pretend like mitochondrial dysfunction occurring in your pelvic organ of interest is happening in isolation is really ignoring very obvious systemic changes that are occurring because people's organs don't age in isolation. And so it's really important to think of this hierarchy, to figure out where in the hierarchy you are, and to think longitudinally, because if you look at a cross section in time, you actually can't tell if you're measuring a compensatory or resilience mechanism, or if you're actually measuring what has declined with age. And these things have to be assessed in both preclinical and human models over time. And then you also can't ignore all of the other changes that are occurring simultaneously in all the different organs through often the identical biological age mechanism that you're measuring in your organ of interest. So I'll get a little off my soapbox and kind of tell you how I have tried to take this framework that was largely built for other age-related diseases and leverage it for studying geriatric LUTs. I kind of took these buckets of biological aging, and I think I've been showing this at CAIRIBU talks for the last many years, but it has evolved somewhat. We really have no idea which biological aging mechanisms are relevant to geriatric LUTs, but I'll tell you at the end of this talk about a few initial studies that are looking at this. There have been many, many studies over decades looking at phenotypic aging measures. I've listed many of the popular ones here and looking at their association with LUTs in older adults. You'll see that there's a mix of ones that are systemic, chronic inflammation, insulin resistance, maybe more organ specific like white matter disease. And then there's several that are pelvic floor or bladder prostate specific phenotypic aging measures that we know are associated with geriatric LUTs. And then a lot of my work actually in the last several years have been actually documenting the functional aging measures and how they are related to LUT severity to build the case that this framework fits. So we have known for decades that many phenotypic aging measures are related to LUT severity. And now in the last several years, we've demonstrated that functional aging measures are very clearly associated with LUT severity in older adults. And so 2 of the 3 measures of aging seem to be panning out. And really the next step is to start to study and target biological aging. And what's cool about this framework is that there are interventions that have are in development and or have been proven to work for other age-related diseases. Starting with multi-component interventions, it does not work to target single phenotypic aging mechanisms for most age-related diseases. You almost always cannot just knock out inflammation and expect a systemic age-related disease to get better. And so when we look back and see, has that worked for age-related urinary symptoms, whether it's prostate-specific or bladder-specific, I'm not surprised that targeting inflammation has not worked. I doubt that we just need a more bladder or prostate-specific anti-inflammatory intervention. It's most likely the fact that we're trying to target a single phenotypic aging manifestation in a multi-system, very complex system. Similarly, I doubt that if we just improved insulin resistance and ignored all of these other phenotypic aging measures, whether geriatric LUTs would get better. Multi-component interventions, the idea behind that is that you target multiple of them simultaneously. And this can actually be across any of the different buckets of aging. It can be, you can address the biology of chronic inflammation simultaneously as trying to decrease white matter disease and improve skeletal muscle function while also targeting the bladder. You can also have ones that are a mix of phenotypic and functional aging. So you're addressing the phenotypic aging processes while also making sure that people's mood and sleep is appropriate. And this has been shown, particularly in hospital-based delirium and falls prevention, to be much more effective than ever targeting any one of these things in isolation. The other exciting thing about this framework is that biological aging has been understood in a much more deep way over the last several years. There are many companies that are trying to develop drugs that target mitochondria or telomeres or other hallmarks of aging. And there are also some lifestyle factors that are kind of the original geroscience interventions. Exercise and caloric restriction are very effective modulators of biological aging mechanisms, and those also fit into this framework. So I kind of mentioned that I have spent some of the last couple of years demonstrating that LUTs are sociofunctional outcomes. This is just an example of that. We showed that as an older man develops greater phenotypic frailty, their AUASI increases, and this is in a group of men who have no symptoms at baseline, using kind of complex longitudinal modeling. And adjusting for differences in baseline, really trying to get at, is there something causal about worsening frailty that leads to worsening LUTs, and our analyses are suggestive of that. We also show that men who have LUT severity in categories that are not clinically targeted or considered to be quite mild still have clinically meaningful increased risk of functional aging outcomes. So mobility impairments, the inability to walk a quarter mile independently without help. For men who have an AUASI score of 0 to 3, they have almost no risk, particularly among younger men. But even those with moderate LUTs and AUA score of 8 to 12, they have almost 2.5 times higher risk of having new mobility impairments in the next 2 years. And so when you start to look at aging outcomes, many of the cutoffs that were used for drug trials are not going to be the same ones that are important to target for aging mechanisms. We're going to need to rethink what degree of LUTs means someone that has a higher risk of outcomes that we care about and the patients care about. This has led me to really think about how we characterize and describe age-related chronic conditions, and whether or not the traditional medical model lens is working. I've kind of hinted at the fact that I don't think it is, but I'll kind of give you 2 LUTs examples, one prostate and one bladder. The first is benign prostatic hyperplasia. That's the pathophysiology that we know leads to obstruction, and what has been assumed for a long time is that obstruction leads to voiding LUTs, and that the arrows between each of these is very strong, that those who have BPH almost inevitably will have obstruction, and those who have obstruction will almost inevitably have voiding LUTs. And therefore, if someone presents with voiding LUTs, you can kind of work backwards, and presumably most men with voiding LUTs have BPH. That's kind of how the traditional medical model lens currently thinks about it. Alternatively, detrusor activity, if the bladder is contracting before the bladder is full, that almost certainly would cause storage LUTs, and vice versa. If someone presents with storage LUTs, the vast majority of them will have some degree of urinodynamically confirmable detrusor overactivity. In this case, detrusor activity is idiopathic in most cases, and the etiology itself is unknown. But this is what both detrusor activity and BPH might look like in a traditional medical model lens. I thought that I could follow the same perspective and study an age-related phenotype. And I was, I had read in the literature that sarcopenia, which is age-related loss in muscle strength and function, was explaining a large amount of female urinary incontinence. And so I wrote a grant to study that, and I thought that I would similarly find a nice big arrow, just like many of the other pelvic floor LUTs etiologies. In order to do this, I took a cohort of, and actually it's 900 women and men, about 500 of them were women, all age over 70. They have very comprehensively assessed physical performance, strength assessments, objective and subjective, muscle mass by the gold standard assays, muscle volume by full body MRI. They have power assessment, which is strength over time, that are all very comprehensively assessed. And then we added the Learn SI10 questionnaire to that cohort, which has both the most common LUT symptoms that are assessed for clinically and a bother question. And then we looked at the correlations, and I thought, okay, there's been literature on sarcopenia and incontinence. And now that I have very specific muscle measures, I'm going to see really strong correlations, independent of other age-related things that we know contribute to particularly female incontinence, obesity, multimorbidity, polypharmacy as indicators of other age-related conditions. And what was really humbling that we discovered, this is a very busy slide. One, the main takeaway was that we saw very little in men. I'm not going to focus on that today. But when we looked in women, so this first column is the total Learn SI10 score. The next column is urinary incontinence subscore. So that's a combination of 3 incontinence questions on urgency, stress, as well as physical activity-induced incontinence, and then other subscores, kind of the column subsequently. And what the main takeaway here is that the measures that were most strongly associated with the total LUT score, as well as the urinary incontinence score, were actually more comprehensive global aging functional assessments, how quickly someone can walk a quarter mile or 400 meters, whether or not the SPBB is a multi-component assessments of their balance, of their gait speed, and of their strength, as well as self-reported assessment of mobility. Those were the things that were most strongly associated with incontinence. But when you dove down and you looked at biological measures of muscle using gold standard assessments, the correlations disappeared. And so, they were weak to start with, and then they really became weak to non-existent. So suggesting that actually, again, following this very traditional medical model of there must be one specific thing wrong, and if I can identify that specific pathology, that I'm going to see a strong, and I measure it in people with for example, incontinence, that I'm going to see a pretty strong correlation. The opposite was true. The measures that correlate most strongly with LUTS, as well as urinary incontinence specifically in older women, are fully integrated measures of healthy aging across the entire body. And when you dive specifically into muscle, those associations become much weaker. So what I found, and what I've kind of diving back deeper into literature on the relationship between obstruction and voiding LUTS and detrusor overactivity and storage LUTS, and now I've confirmed in sarcopenia and female incontinence, is this arrow is extremely small, and the relationship between the pathophysiology here and the presenting symptoms is very weak. It doesn't mean that it's not the cause of symptoms in specific older adults, but I kind of fell into the trap that I had been criticizing in my grants, which was that I was targeting using a traditional medical model lens to target a specific pathophysiology and a specific urinary symptom, as opposed to thinking about the entire body. And what I found was it was the integrative measures of function pointing towards maybe a systemic aging process that were actually the most strongly associated with whether it's LUTS as an entire syndrome or urinary incontinence specifically. And so for those that don't know what geriatric syndromes are, instead of thinking of a specific etiology where that's often traditionally a gene mutation that causes pathogenesis in a group of cells or a tissue, and that leads to a set of presenting symptoms or signs or symptoms in certain cases, geriatric syndromes are much messier. There are multiple etiologic factors. The contribution of those etiologies to pathogenic pathways is they all interact with each other. So it's extremely difficult to identify a single cause, a single etiologic factor leading to a single pathogenesis. And yet they all lead to the end of that pathway is a unified manifestation. And so an example of that might be urinary incontinence in an older, frail adult. And this probably sounds horrific to most people who are used to thinking of trying to identify singular causes of diseases. But some very smart people who have gone on to make very impressive improvements in how we care for other geriatric syndromes, such as delirium or falls, say that you basically cannot take this traditional model and make any sort of improvement in geriatric syndromes. And so if certain subsets of LUTS or LUTS in certain people is a geriatric syndrome, then we can't keep trying this traditional medical model and expecting different results. We really need to start thinking about multiple interacting etiologic factors leading to multiple interacting pathways and ending in a unified manifestation. I think I'm going to skip this slide. But the main point of this is that geriatric syndromes, they share several risk factors. They interact with frailty because frailty can both cause a geriatric syndrome, but then geriatric syndromes worsen frailty because often someone becomes less active. Their nutrition starts to decline, and that worsens the frailty mechanisms that are contributing to the geriatric syndrome in the first place. And then they really end in these geriatric outcomes that have a lot of overlap with the functional aging outcomes that I mentioned earlier. And I think that geriatric LUTS is a classic one. Incontinence has always been described as a geriatric syndrome, but we really don't study it like that. In translational studies and even clinical studies, we don't have a definition of incontinence, the geriatric syndrome, versus incontinence caused by something with a specific etiology. And I think that we need to get some clarity around that. So in the last 10 minutes, I will describe what these other people who are smarter than I am think that we need to do in order to improve and enhance progress studying geriatric syndromes. And that includes geriatric LUTS. The first is to test broad pleiotropic effects of agents or behavioral modifications, exercise, nutrition, and weight loss being classic examples on relevant outcomes for your geriatric syndrome. Then explore the mechanisms by which these interventions exert their effects that are beneficial in your specific geriatric syndromes of interest, and develop and test unified intervention strategies based on these shared risk factors across geriatric syndromes, and test long-term outcomes. And then once you have demonstrated that doing this multi-component approach works for a geriatric syndrome, then come back and try to improve your understanding of these very complex interacting pathways of geriatric syndromes through mechanistic models that actually embrace that complexity rather than trying to distill it down to a single pathway, which is basically irrelevant to most geriatric syndromes. And it kind of accounts for multiple pathways and synergism between pathways, and kind of iteratively work through improving these pleiotropic interventions with that enhanced pathophysiologic understanding. That's a lot of words and a lot of kind of high level thinking around this. I'll kind of now talk through ways that our group has implemented this approach, and others that I'm aware of we're either collaborating with or are interventioning it themselves. I forgot I had the slide. Before I do that, there are still some really big questions that I have about geriatric LUTs and how to attack them as a geriatric syndrome. The first is that I have no idea how to distinguish geriatric LUTs when age-related genitourinary changes are basically ubiquitous. Pelvic floor muscles and urethral sphincters weaken in basically every single person, some more than others, but many people have these genitourinary changes and no symptoms. So I don't know how to, and similarly, bladder capacity we know decreases with age, prostates grow, they obstruct, but they are not causally always related to the symptoms. And I actually, when these changes are universal, I don't actually know how to identify those who are, if you targeted these, it would improve things versus those who have this more complex geriatric LUT syndrome. One way is to compare extremes. To address this problem is to compare extremes. So take those who have significant age-related GU pathology, but no symptoms, and compare them to those who have symptoms and no age-related GU pathology. What makes someone resilient to age-related GU pathology, and what symptoms are not related to age-related GU pathology because they're present in people who have normal bladders, normal prostates, normal pelvic floor muscles. The other approach to addressing this problem is, let's get the GU pathology out of the way. And how do we do that? Well, we look at treatments that we know are effective at targeting GU pathology. We know that we can shrink the prostate and relieve smooth muscle obstruction related to excessive smooth muscle resistance. We know that we can paralyze the bladder with Botox and or antimuscarinics. But if someone receives those treatments and fails, they still have symptoms. The symptoms don't improve as you would expect, or they progress despite these symptoms. Instead of doubling down and saying, okay, this person failed the first line GU targeted therapy, now we should go to the second and third line. Actually, maybe that's a sign that the GU pathology, even though it's present, is not causing their symptoms. Maybe we need to study this treatment failure group in a different light and not think of them as someone who needs to be escalated, but someone who actually needs a more broad diagnostic approach. The other is that I don't know how to measure and summarize pleiotropic intervention effects when multiple organs are changing simultaneously on a unified manifestation. We're going to give them an intervention. We're going to see a change in the bladder or see a change in the prostate, but their brain is going to change, their muscle is going to change, their heart is going to change all at the same time. And I don't really know how to tease those things apart. And then lastly, identifying and targeting these modifiable risk factors for complex multifactorial geriatric syndromes is very difficult. So those are unanswered questions. Here's what we've done. We took the NTOPS trial. It's a clinical trial of BPH medications over 3,000 men. We created a frailty index using existing data, and we looked at the primary outcome of the trial and used the same analytic approach that they used in the original trial. And people who are frail failed at much higher rates, had clinical BPH progression at much higher rates than men who were robust. In clinical practice, this frail group is called a medical treatment failure, and they get referred for surgery. But maybe instead of referring them for surgery, we need to actually study them and figure out what is biologically different about them. Maybe they have geriatric LUTs, not drug-resistant BPH. I'm gonna skip that. Another thing that we're trying is we're using pleiotropic interventions that we know work. We know exercise has effects across multiple different organ systems that have been shown to be related to urinary symptom severity. So let's have older men who have persistent LUTs and many of them have actually failed medical treatment. And let's get them to exercise, increase their aerobic fitness, increase their muscle health, and let's see if their LUTs improve. And then we'll study the mechanisms through which exercise improved the LUTs. We have enrolled randomized our first 3 participants and have 20 men who have passed our screening for the PROUD trial, which I'll tell folks a little bit more at the upcoming CAIRIBU Summit. A cool thing to know about this is that we collected a whole bunch of biomarkers as specimens, urine, isolated plasma and serum, whole blood for epigenetics. We're isolating PBMCs and platelets, and we have several funded biomarkers, but there's many other biomarkers that could be looked at to try to figure out how exercise might be improving LUTs. A colleague and collaborator, Iman Nagar at University of Connecticut, is using a geroscience framework to test whether a mitochondrial antioxidant is improving LUTs in middle-aged and older women who have metabolic syndrome. This is really going straight to targeting biological aging and seeing if it improves what is likely a geriatric LUTs phenotype. Teresa Liu and Will Rickey, who you guys know well, are testing exercise in mice, and the preliminary data on that is very promising. When you take young and old mice and you let them exercise, the old mice look a lot more like young mice very rapidly, and the effects seem to be through mechanisms independent of body mass. They're doing exciting work there. Another collaboration with a group at University of Madison, Wisconsin. They're testing dietary interventions in mice to improve functional aging, phenotypic and functional aging. But if you happen to measure their urinary function in the mice, turns out their urinary function gets better with dietary interventions that are designed to target biological aging mechanisms. So I hope that we see more and more of this. There are 1 million geroscientists out there testing aging-related interventions. We should be making sure that and advocating for urinary outcomes to be included in their preclinical and their clinical studies. And then lastly, on the clinical side of things, Dr. Candace Parker-Audrey, a urogynecologist at Wake Forest, has really been trying to tackle, we've said for decades that incontinence is a geriatric syndrome, but how do you define it clinically and what do we do differently about it? It turns out we treat older women with suspected geriatric incontinence syndrome the same way we treat younger women or more robust women with urinary incontinence. We treat them the same way and assess them the same way, and that's probably not the right way to go about it. So she's working on developing diagnostic criteria for the geriatric syndrome of incontinence. So those are just examples of taking this framework and applying it. There's lots of people I have to thank at UCSF, UCSD, and UC Berkeley, who have helped me with this work. Many CAIRIBU collaborators, particularly Teresa, Will, and Doug, our proud exercise study team, and then our funders. And I just love this cartoon, so I always show it. Thanks, and hopefully I left a little bit of time for questions.